Yes? Good. Okay. I hope people on the Zoom can hear that, this things, but they're asking all the right questions. And I haven't looked at this since last year, so let me go on and see what we have. So no fevers or chills. She doesn't have any cough, ear pain, nasal congestion, no belly pain, nausea, vomiting, no ill contacts, but does go to school. And we'll assume it's in-person school. And her shots are up to date, but she did not get a flu shot. So here's her exam. Looks like, a little bit, a mild fever. I'm sure her normal temp is 96 though, so this is, as they sometimes tell you. Her HENT exam, she's got some erythema of oropharynx and some tonsillar exudate and some anterior cervical lymphadenopathy. The rest of her exam was pretty normal. So what are we thinking? Let's hear a differential diagnosis. Strep, mono, viral.
That's like maybe like a peritonsillar abscess.
Yeah. Yeah. And yeah, I guess you probably throw COVID in because it is until it's not. Good. So strep pharyngitis, it's commonly seen in kids of school age. It's about 15 to 30% of pharyngitis in kids in that school age range of 5 to 15 years. It's the most common cause of a bacterial pharyngitis. Typically, this is kind of an abrupt onset, like they felt fine, then boom, they didn't. And, as you can see from the clinical features, sore throat, fever, headache, abdominal pain, nausea, vomiting, absence of coughs. You want to rule out those other kind of URI symptoms, so no nasal congestion, no cough. What'd you say, Dr. Tim? Flu. And COVID. All right. So, common clinical features, you can get the rash, palatal petechiae. That's kind of a thing that really kind of ups my strep radar. Tonsillar enlargement, plus or minus exudate, vomiting, tender cervical nodes. Kids less than 3 may present a little bit differently. They may even have a little bit of a runny nose, low-grade fever, and may just be fussy or not eating well. So who do we test? People that have evidence of abnormalities of the tonsil. So those erythematous and plus or minus exudate. If they have the rash, then you would want to test them. And if people don't have sort of those other viral symptoms, that cough, runny nose, conjunctivitis, hoarseness, anterior stomatitis, ulcers or vesicles in the throat, that's not going to be a strep or diarrhea. If they don't have those things with the sore throat, you would really want to think about it. Or if they've had exposure to somebody at home or school and they have signs of it. Often if a sibling has been actually tested and now another sibling has it, then I typically don't make them be tested. But I do always try to hammer down with the parents, like, how were they diagnosed? What did it, so did they go to prime time and they just said, oh, they got strep, or did they actually get a test?
Well, and the whole mom and dad, first mom, the blisters,
Mhm.
They say it all the time. Well, sometimes blisters are actually like activated pockets. Sometimes blisters like a hospital with.
Mhm.
But a lot of times blisters are ulcers, and they just go like self-evident when you get too much stress. You have to do a lot of education about what you're seeing and why it's not stress.
So everybody's, I hope, heard of the Centaur criteria. Can anybody tell us what those are? Good. So, you know, if you have 2 to 3 of them, it's considered positive.
It's also an acronym. I didn't know that. It's like studying for it long. C is like no cough, E is or it's a less than the other one is like
It's what medical school is acronyms.
Hey, Dr. Wilson.
Yes.
Just for the people who are tuning in virtually, there are a lot of long pauses that make me feel like someone else is talking, but can't really make out anything that is being said.
Okay. I apologize. We will try to help with that. So could you guys hear? Well, and I guess we've listed them now. So Warren was also saying that you know it's an acronym too, with cough, the Centaur cough, exudate, lymph nodes, and then temperature, and then OR is the age range. So there are some different types of tests that you can do. There's a rapid test, there's a culture. You know, typically a lot of times here, if it's negative, they'll ask you, do you want to send it for a culture or not? Typically I go ahead and say yes, unless I only really did a rapid strep to appease somebody. Know that collection, how it's collected is important. You know, sometimes the MAs, particularly, you know, like if it's, you know, somebody's kid they know, they don't want to, you know, I mean, it's uncomfortable. You have to touch the tonsils. You have to get the right stuff. So, you know, if it really didn't gag the kid or traumatize them a little bit, they may not have done it correctly.
How do you do it? How do you collect? Has anyone ever collected a strep themselves? Dr. Tim? Dr. Ferguson, Yoder, Chelsea? Okay, so how do you do it?
So
Dr. Tim sticks them in the corner.
yeah, so they're heavy in the corner.
So the head's in the corner,
Yeah.
in the corner of the wall.
Otherwise they'll like try to stop it. And then you gather back.
Dr. Tim's making a jabbing motion.
They're smaller than candy. Yeah.
There's discussion about bribing with candy. Tonsils and posterior pharynx. Yes, you need to get both tonsils. You need to get the soft palate, and you need to get that posterior pharynx to be able to get a good sample. As far as tricks, I like having the kiddo sit on mom or dad's lap, lean back on mom and dad, have mom hold the forehead and wrap the other arm around the child and hold firmly. Sometimes it's good to have an MA or someone in the room with you to help. I don't mind to get my own strips if I'm not that busy because I want to make sure that it's done properly. And our MAs do a great job, so please don't hear that as any kind of criticism. It's just when I know the kid's going to be difficult, I'd rather just do it. So anyway, and then also, just for a quick review, if it says this high specificity, what does that tell you about the test? limited rules in on specificity, right? So if your rapid strep turns positive, how confident do you feel that this patient has strep? Very confident, right? But the sensitivity suffers a bit on the rapid test. So that's why Dr. Wilson was saying, send that off for culture, because we've seen lots of times when that comes back positive later because of that sensitivity issue. So it doesn't always rule it out.
Then how do we treat strep? What's our antibiotic of choice? I'm sorry?
You're shooting people up with penicillin over here. Who else? What's the treatment of choice?
Dr. Burns has said amoxicillin.
And I don't know if technically the literature says penicillin is probably better, but I usually do amoxicillin.
Okay. What about your pen allergic kids? What about your kid that had a reaction to cephalosporin before? I'm sorry? Okay. Sabrina's saying tetracyclines. Anybody have any other ideas? All right, so yes, penicillin is the drug of choice. It's the recommendation.
Why do you think that is? Why should I pick penicillin over amoxicillin? It's a narrow spectrum, right? We give everybody amoxicillin for strep throat, and we are increasing our, drug resistance potential, and it's not a very good antimicrobial stewardship, right? So if it's an adult and they get diagnosed with strep, give them penicillin. Okay.
Yeah, I mean, amoxicillin is the bubblegum medicine of childhood, so definitely tastes better, easier to get a kid to take. Yes, we can use our single dose of benzathine penicillin. Definitely, perhaps if you have a child that you're worried that the parents are not going to be able to complete the course, or that they maybe lost a follow-up, there's definitely a role for this sort of thing. And then kids that have a history of rheumatic fever or a high risk for cardiac complications from strep. Sorry, again, I'm just reorienting myself to this too.
Yeah, you guys pretty much said all this. If you have a non-IgE mediated reaction, then you can try cephalosporin, particularly the higher the generation, the less the cross-reactivity there. I use Keflex quite a bit in kids and adults. And then you can also use that third generation cephalosporin, and then you guys are talking about cephalosporin because of the even reduced cross-reactivity that you find in that third generation.
And then it only needs 5 days.
Yeah.
If it's a third generation, so that could be a reason for that, for choosing that.
Yeah. But the Keflex and stuff, you still have to keep for 10. And then for severe angioedema or anaphylaxis, you don't really want to try cephalosporin until they've been tested by an allergist. And so you guys put out some other options. You can use Clinda. You can also use a macrolide, but you have to be aware that resistance is increasing for our macrolides. But we've treated plenty of strep with Zithromax. Now, tell me the dosing difference. This is very important. How do you dose a Z-Pak for like bronchitis or something? You guys, I feel like my heart's gonna come out of my chest. I love that answer. Okay.
If you were to.
If you're giving it for COPD exacerbation, there's something that it's indicated for. 500 and then 250 times 4, right? So how do you treat a strep throat with azithromycin. Well, yes, all pediatric medicines do.
Dr. Eliades is hardest.
Please see me afterwards. Yeah, but what's the difference?
I would look at them on.
Okay.
Yes. You do not do bolus dose. But if you're treating a kid for a Z-Pak, what's the dose?
45.
No. Thank you for trying. It's 10 mg per kilo for the first day, then 5 mg per kilo for days 2 through 5. So that's like a pediatric Z-Pak. So what's the difference, Dr. Wilson?
So for strep, though, it is not that. You do 12 mg per kg for 5 days. So if you give them just kind of the Z-Pak dosing, you are not going to adequately treat that. You're going to expose them and increase their chance of resistance.
And I honestly don't know, when they do the antibiograms, if anyone's ever really studied whether the resistance rate has anything to do with someone potentially incorrectly dosing the azithromycin. So if anyone on the Zoom has any info about that, we'd love to hear it. But it's 12 mg per kg times 5 days. Is it our local? I don't know what our local lender resistance is to group A strep, but it is high for group B strep.
So, yeah, it's also getting higher for MRSA.
And getting that.
All right. This is just a list of, some of the complications that we can see from strep. Obviously, things like peritonsillar abscess, if it's not treated, bacteremia, nephritis, fasciitis. But then we have the non-suppurative things like acute rheumatic fever, post-streptococcal glomerulonephritis, and then post-streptococcal arthritis.
Before you put that, which ones are helped by antibiotics? Rheumatic fever. Yes. Peritonsillar abscess. Suppurative conditions and rheumatic fever. Yeah. Okay.
So the group says all the suppurative complications and rheumatic fever. And they were almost right, but also includes post-streptococcal glomerulonephritis.
Well, and it's May, so I'm going to give it to you guys.
That must have happened in the last 2 years.
Yeah. I don't know if you know this, but medicine changes. There's something called a pandemic.
You take it from Dr. Bunch, who was in med school when penicillin was invented.
That's right. Hey, when I was in med school, there was no such thing as a PPI. Okay, sure. So acute rheumatic fever is the leading cause of cardiovascular death in people under 50 on a global scale. Okay, not necessarily in the United States, but on a global scale. Most cases are first found in the ages of 5 to 15. But we know that the adequate treatment of group A strep pharyngitis reduces the incidence of acute rheumatic fever tremendously. So we see this primarily in our low and middle income countries, and it is the only type of group A strep infection that's associated with acute rheumatic fever. That you guys probably remember from medical school. The skin group A strep is not associated with acute rheumatic fever, only the pharyngeal form. Okay, so we know that we have the Jones criteria, right? And so the 3 major manifestations are carditis and valvulitis, arthritis, CNS involvement, Subcutaneous nodules and erythema marginatum. The 4 minor manifestations are grounder fever, elevated ESR, CRP, and then the prolonged PR on the EKG. That one's sometimes hard to remember, right?
This is the Jones is also a acronym, right, Warren?
Yep. Joints. Heart.
Joints.
And it's subcutaneous nodules.
What's O?
The heart.
O is a picture of a heart.
N is
E is erythema
erythema
marginatum, and S is Sydenham's chorea. But D is what? Oh.
Not included.
There's no D in Jones. Oh, I got it all together. So anyway, you have to have 2 major or 1 major and 2 minor to make the diagnosis, right? Okay. All right, here's the question.
You guys want to read it? Or do you want me to read it to you? Like, I know you can't read. I think she wants this going.
He wants all you people in his name to be gone.
So this was on last year, like last year's IT exam, not the one you took this year, but the previous.
And we included questions that a high percentage of people missed.
All right, who thinks A? Okay, we got some
Got a
A's.
couple A's.
B. Is that a head scratch, Steiner? Okay. C.
Dylan says give them all hydrocodone.
and D.
Okay, so we have quite a few D's.
Which is good because NSAIDs are the first line therapy, often with a dramatic response. So good. So Dr. Yoder has very wisely asked about the kidney function. So we would want to make sure that was okay. So kind of the goals of treatment of acute rheumatic fever, we want to obviously give them symptomatic relief. So particularly NSAIDs are indicated for their arthritis. Naproxen is preferred. I don't recall why.
I think it's the safest cardiac medication, and then also its dosing is a little easier because it's twice a day.
And then obviously want to eradicate the group A strep. Again, here we're going to use Sabrina's IM penicillin if we have it. Otherwise, we're going to use whatever we can to treat group A strep. And then you have to prophylax them against future group A strep, rheumatic cardiac disease, which is every 3 to 4 weeks. They're going to be getting IM penicillin until they're 21 years old. I'm sorry?
A lot of penicillin.
Yes, that's a lot of penicillin. So, and then you would want to screen their household members. You know, you definitely sometimes have those asymptomatic carriers, and you would want to try to treat them if they're positive.
Find those typhoid Marys. This is something that is really important too for your kids that keep coming back in for group A strep infections, and you just are like scratching your head, like, what the heck is going on? I've had that happen once in a while in my career, and then I screen family, and you'll find like mom has asymptomatic group A strep. You eradicate mom, and then that kid gets better.
You eradicate mom's strep, not mom.
I just heard that. That's good. What?
Yes.
Yes. Yes, thank you. Get rid of the toothbrushes. If you have an electric one, soak it in some peroxide in water. I run our toothbrushes through the dishwasher if they're brand new. Something to in the toothbrush drawer. I don't know about your house, but my kids, that drawer is nasty. So we gotta wipe the drawer out. You know, think about all those things that, you know, if they share like a cup for brushing their teeth, help parents talk about like how to disinfect and clean the bathroom area for that. Thank you for bringing that up.
And then, yeah, definitely you want to provide education for these parents. These are kids that you do need to treat their sore throats early. And if the kid is on their monthly penicillin, you need to use something other than penicillin to treat an acute sore throat. And good oral health with their new toothbrush.
And clean toothbrush drawer.
And then for your females, you need to discuss the risks of pregnancy. And the benefits. Yes, Dr. Steiner, and the benefits.
Dr. Wilson, you may have already seen this or addressed this, but Dr. Mattoon had a question. I had read not to use NSAIDs until diagnosis was confirmed. Can you explain that?
In the chat, I don't know if you heard it, but he just
She
said
said if she had read that not to use NSAIDs until the diagnosis is confirmed. Well, you have the diagnosis by meeting your criteria. So if you meet your criteria for acute rheumatic fever, you can implement NSAID therapy as long as their kidney function is normal. I'm not sure what you meant besides that as far as confirmation.
This is Dr. Witt. I can speak into this a little bit, and there are maybe one confusion point is that are you treating acute rheumatic fever, or are you treating a post-streptococcal reactive arthritis or Reiter's syndrome? And the latter tends to have less inflammation, and it does not respond to NSAIDs, whereas acute rheumatic fever has a very high degree of inflammation and it responds very well to NSAIDs. So I'm not sure if, in your question, Jocelyn, if you had maybe been reading about like a post-streptococcal arthritis versus acute rheumatic fever.
Thank you. Good point.
what are the utilities of getting volume where it literally met all the criteria, most like they met criteria for that
Oh.
Because I even called the executive, like, why are you talking about cardiology? They have COVID. So like, oh, wow.
So Dylan's asking the utility of using like an ASO that we are going with.
ASO.
DNAs for the diagnosis of acute rheumatic fever in terms of like confirmatory. Right, exactly. And so if you have a recent group A strep pharyngitis infection and you have the criteria, I'm not aware that you have to get an ASO or DNAs to prove it. We do talk a little bit about that as far as the post-streptococcal glomerulonephritis goes, because there's more utility in using it in that instance as opposed to the acute rheumatic fever. But now in the age of COVID, if you don't have an antecedent infection, and I guess even pre-COVID, you really do need to get those to show that there's been an infection, but also rule out other things that could mimic, because we know that you can have cardiac manifestations of COVID. Yeah. Anything else? Anything else from on the chat or on the Zoom? Someone's talking? No? Okay.
So as far as other complications, then we have the post-streptococcal glomerulonephritis. This is the most common cause of an acute nephritis in kids globally, mainly seen in developing countries. It's decreased in industrialized nations, thought to be because of easier access to treatment for strep infections, and also the widespread presence of fluoride in the water. And again, this in contrast to acute rheumatic fever, post-streptococcal glomerulonephritis can happen from both a throat infection and a skin infection. Go through this part and just put it on.
So it's triggered by these glomerular immune complexes, and that stimulates the complement, and then that causes all the inflammation. So clinically, they come in with lots of different things. They have asymptomatic microscopic hematuria, but they can have full-blown nephrotic symptoms. So it's a very wide range that they can present. So a lot of them will present saying that their urine was brown or red. Don't blow that off. Make sure you get a urinalysis. A lot of them will have proteinuria, and again, it can get as high as the nephrotic range there. Many will have edema and hypertension. This is a really interesting component, because some kids, maybe they come in for a well visit or something and their blood pressures flew up. Ask about any recent infections, because I've seen post-strep glomerulonephritis present with just a little bit of high blood pressure. And then elevated creatinine, so you'll definitely want to get your labs. There is usually an antecedent history of group A strep, skin or throat. And then the latent period is like 1 to 3 weeks after the pharyngitis, but a little bit longer for the skin. Okay, so just keep that in mind, particularly if you see those blood pressures. That can be a little hint. Okay, here's the question. Guys, take a moment and read through that, and then let us know what you think.
All right, so everybody read and came up with their answer. So A, B, C, D, and E. So it looks like the majority said B.
Yeah, but I'm sitting in the Dylan's, for the record, Dylan's very committed, he said. So the RBC casts, when you see RBC cast, it generally suggests an underlying proliferative glomerulonephritis. So would you expect to see GPCs in chains? Not in the urine, right? That's what we would see if we looking at the strep or the skin under the microscope, but not in the urine. And what a white blood cell? No. What did white blood cell casts make you think of? Yeah, it's more interstitial, and these RBCs are more like the glomerulus. Okay. And then eosinophils, what do you see with that? Those are acute interstitial nephritis. But the absence of them doesn't rule out AIN, right? Just the presence makes you think more heavily of it. Dr. Justin Anderson orders a lot of urine eosinophils. So if you ever rotate with him, he will be very impressed. If you say, hey, I think we should order urine eosinophils, he will oh. And then oxalate crystals. stones? Yeah. They can be without stones too, but we see oscillate crystals all the time. All right, so post-streptococcal glomerulonephritis, the diagnosis, you have to have findings of both acute nephritis and recent infection. All right, so nephritis is diagnosed with the hematuria with or without the RBC casts. You don't have to have RBC casts to make the diagnosis, but the presence of such makes you very suspicious. And then variable degrees of proteinuria, edema, oliguria, or hypertension. And then the recent infection, like you were saying, you know, we have to show that there's been a recent infection. If there's any question, then get that ASO. Okay. All right, so how do you treat it? Antibiotics if there's infection is still present, like if there's still an active pharyngitis or skin infection, because it has been reported to reduce the severity. But if there's no active infection, there's really nothing to treat in terms of antibiotics. The care for post-strep glomerulonephritis is supportive. So you can use some loop diuretics. That does help. ACE inhibitors, you have to be very careful with those for reasons you guys are very aware of. Hypertensive encephalopathy is very rare, thankfully, but if it does develop, these people respond pretty well to nifedipine. And the need for dialysis and fulminant kidney failure is also thankfully quite rare. But those kids with those blood pressures, think about it. Yeah. Yep. Yep. All right, here's another question. And we're going to add to this, we're going to do another session for more pediatric infectious diseases and things. We've got only like 5 or 10 minutes left today. But we feel like it's kind of helpful to go through these board questions. And if you guys have suggestions, we'd love to hear them.
All right. Who thinks it's A? B. Anybody know how to pronounce that? C. Okay. D. And E.
Doesn't that make you think like of a Christine? Yeah.
So yes, the correct answer is D, or Sean line for HSP.
Can I make a statement?
Yes.
So
You have another option.
a bunch of people made fun of me last year because I said on the board exam, 9 out of 10 there's a butt rap to account from the purple. And people thought that was so funny that I was right. And I feel like the boards, the best way to remember it is if they have butt purple rap, that's probably how it's done.
Okay. For those of you on this, for those of you who are on the Zoom, there's quite a discussion happening about butt rashes. But Warren is very convinced that if there is a question on the boards about a purpuric rash that's on the butt, there's a high yield in choosing HSP. So,
and he's usually right.
Yeah, and he got this question right, and about 80% of our team did not. So perhaps you should look at it. Well, that's why we picked these questions, because they were like at least 60 to 80% of people missed them. So thanks for letting us know that you got it right, Warren.
And Laura, can you pat him on the back since you are sitting behind him?
There's like a lot of clapping for Warren right now.
So kind of looking at the other answers. So erythema infectiosum, or Fifth's disease, it's kind of your slap cheeks. Typically start with fever and runny nose, headache, and then the rash starts about 2 to 5 days later. And again, it's that slap cheek rash on the face, and then it may have kind of a lacy rash on the trunk and extremities. May have some arthritis or joint complaints. Aplastic anemia can be found, and this is caused by parvo B19. Why do we care about this one?
I heard someone. Torch. Pregnant. I heard pregnant.
Yeah. Yeah. So, you know, definitely if your pregnant patient says that they were around somebody that had this, it is important to check their antibody status and see, because an acute parvo B19 infection during pregnancy can be really bad. So evidently this really is a thing. Also known as papular acrodermatitis, which is probably easier to say. But this is a self-limited skin disorder in young children. It's going to be a symmetric papular eruption involving the cheeks, buttocks, and extensor surfaces. It's usually preceded by a URI or a GI illness, and they're going to have normal labs. So typically another strategy is like the exotic things that you don't know are usually not a great choice. Would you agree with that, Dr. Lawless? Yeah. Okay. HUS, really kind of for this diagnosis, you're going to see the microangiopathic hemolytic anemia, thrombocytopenia, and AKI. Typically occurs after infections, things like Shiga toxin producing E. coli, strep pneumo, or HIV. It can also occur with drug toxicity, kind of in our cancer and organ transplant patients.
But those labs are abnormal, right?
The kids that go out in the spring or summer and play irrigation ditches with they pick up HUS first. My wife actually had HUS almost died when she was 10. And they think she got it because her dad had spears. So she had E. coli infection and then her kidney started shutting down.
Wow.
She was fine. She had no problem.
That's incredible. Because it's spring and everyone's out playing with the cattle.
Yeah.
Yeah.
So just some stories here about this being a seasonal thing associated with like kids playing in irrigation ditches that might be contaminated with
Cow feces.
feces. And also Annie Yoder had this when she was young. So.
And she was very sick, but she's fine now.
And then TTP, again, you're going to see this microangiopathic hemolytic anemia and thrombocytopenia, but less likely that the kidneys are going to be affected. Usually don't have CNS symptoms. They usually don't have bleeding, and it's uncommon to have a fever.
That's it. The next one is going to kind of jumpstart our next session, which will be kind of a continuation of this, particularly since we're right up to time. Does anybody have any questions or thoughts?
For Strep Pharyngitis, how young will you test somebody for Strep Pharyngitis? I had somebody call in, I don't know, a month ago or so, and the dad had had Strep Pharyngitis, and they wanted to get the 10-month-old tested for Strep Pharyngitis. Didn't really have any symptoms other than it was teething, and so it was just kind of fussy. But I said, gee, this is because the symptoms are so vague.
Yeah.
For like less than 1.
Yeah.
So Dakota's asking, how young will you do a strep test? And told the story of a 10-month-old patient of his whose dad had strep, and the kid was fussy, and the parents wanted him tested.
So, as you noted, the kids that young can have different presentations for it. Strep in that age group is very, very uncommon. If they have a known exposure though, and they're of an ambulatory age, where they're able to put things in their mouths and things like that, and maybe had like shared, like, you know how parents will take a drink of something and then give it to their baby or whatever. A bite of food. Yeah. Then as long as they, you know, have some sort of symptoms and all, they're completely asymptomatic, I wouldn't test them. But if they have symptoms, then I think it could be worth testing. I don't know how you approach it. But.
Yeah, Again, yeah, I wouldn't test an asymptomatic. Is it that though, like, down to a certain age, they don't have the receptors that can? I'll have to look something up.
Justin,
Yeah, with
he always knows stuff like this.
Yes, honey, I'm here.
What do you know about these receptors?
Isn't there something where kids down to a certain age, like they either can't get strep or they can't have complications from it or something?
Yeah, I don't remember the pathophys, but I think that it has something to do with young children who can be carriers, but they are, I don't know if they're not susceptible to the toxin, because group A strep does produce beta hemolytic toxin. And there's something with that I don't know if it has to do with like persistent hemoglobin, fetal hemoglobin, or anything like that. I don't remember the pathophys, but there is something about that. They're not susceptible to the strep toxin.
We'll get back to you about that.
I mean, I have seen it, like, especially like in the ED, you know, they're right at that like 11-month age, and I'll test them and they come back positive. But usually it's when they have fairly convincing symptoms, even though kids less than 3 can present a little differently. They can have like a rhinorrhea and whatnot.
I thought it was like or something, so wasn't that other that maybe probably not strep, but
Yeah. But because of the age, it could be a weird presentation. Yeah.
so you just like
Very good question.
And especially in like the small ERs, like the nurses love to test them all for RSV, flu, and strep. You know,
Yeah.
like, oh, I got all the swabs.
Before
Probably
you
wouldn't have
come
done
in.
that, but yeah, good question.
Anything else? Okay.